an LVAD multi-modality imaging talk. So the first part of it is about echocardiography, and the second part of it is about CT scanning. So my goal, I did this talk last year as well, so I didn't want to repeat the same exact presentation that we had last year. While I want to tell the lab what I want from LVAD imaging, at the same time, I wanted to take this opportunity to go over some of the updates for echocardiography, particularly in the realm of LVAD. And I think that we have, even if I look at last year's literature, we've made quite a bit of strands. Because for us, LVAD imaging, if they equate to patient outcomes, is what is important. So for instance, things that I'm going to talk about are the LVAD ramp studies that everyone hates, right? Because those are difficult to do. We're really appreciative of all the echo techs who come and do these studies while we're doing them in the cath lab. The cath lab hates us for those ramp studies also because they take a long time. It's almost like a 2-hour study where we float a swan in, we get concomitant echo images, and then we use those to optimize our patients as they're being discharged from the hospital, and at any other time when we think that they need optimization, when we can't figure out what their volume status is, or if they're more symptomatic on their VAD settings at the time. What I also try to focus on is that understanding that there are now 3 different types of pump, and they do not behave the same. So if you're extrapolating echo parameters for HeartMate 2 for HVAD and HeartMate 3, we're not going to make any strides on that either, because HVAD behaves very differently from HeartMate 2, and HVAD behaves also very differently from HeartMate 3. Another important caveat is that some of the complications that we all look for, I know that pump thrombosis gets a lot of hype, but pump thrombosis is something that needs both clinical parameters as well as lab analysis to determine whether it's truly pump thrombosis or not. So based on imaging alone is not something that we can determine accurately. And then the idea was to look at pitfalls of how that has changed also, because there's been at least 2 papers in the last 1 year that talk about what are the pitfalls of evaluating pump thrombosis using echocardiography alone. And then, of course, a subject that's very close to my heart is aortic regurgitation, and that's something we're working on. So the idea is to talk about how we can better quantify aortic regurgitation. And particularly now, when I presented this information last year, we didn't have clinical outcomes that correlated with echo parameters. So the question I really want to pose to the audience today and Dr. Nagueh and the imaging folks here is that whether we should use those parameters instead to determine aortic regurgitation accurately in patients with LVAD, because it's widely different from the clinical parameters that have been previously used. So let me start up my presentation here. Is it this one? Which one is it? Which one? Okay, just put it in. Okay. Is it on there? Okay. All right. So I've already talked about what I'm going to talk about. So assessment of LV unloading and RAM studies, then assessment of regurgitation lesions, particularly aortic regurgitation, looking for a thrombus, and I assure you, you will not find one. RV dysfunction and RV failure, and then some troubleshooting, some alarms. So, and then as I mentioned that I'm going to go over some of the updates in the literature. So I've gone over their HeartMate 2, HVAD, and HeartMate 3. The difference between HeartMate 2 and the other two pumps is that HeartMate 2 is an axial flow pump, and HeartWare and HeartMate 3 are centrifugal flow pumps, and they sit on the pericardium. So how that takes into account the pericardial restraint and how the LV's dimension changes with increasing speed is important to understand that it sits on the LV, so the way that the LV shape changes and the LV size changes is also different. Then the speed. Generally, if you're looking at a patient and if somebody throws a speed at you, you should be able to tell which VAD it is because they're different speeds. So HeartMate 2 varies from 8,800 to actually 16,000, but clinically we use anywhere from 8,800 to 11,000. HVAD range from 2,600 to 2,900 clinically, and HeartMate 3s range from 4,800 to 6,200 clinically. So one modality is not enough, and your clinical parameters are important. So one thing I always get from from the lab, from sonographers, is that we have horrible images, which is not true. I think our our echo lab does a great job of getting really, really good images. One of these papers was from Europe, where they actually tried to figure out a newer view for patients who have an LVAD. And what they did was they tried to correlate it with CT scanning and did this kind of a transhepatic view. And in this view, they could get the most relevant information. So the most relevant information for me is the LV size, the LVEF, the inflow cannula position, the RV interaction with the LV, and the septal position. And if you can get me all of that information, that is more than sufficient for me. And what they also found out that this way they could best align the inflow cannula and could get the best Doppler images. So in 2 weeks, I think I'm doing another talk with the sonographers. So at that point, we can maybe have a patient and we can try this view to see if this is something we can incorporate in our clinical setting. So this was done it was not, so it showed that there was good visualization of structures in 93% of the time, and you could see precise LV and RV function. And the inflow cannula, when they compared it with just regular imaging, they could get better pulse wave Doppler of these patients. And so this is what real-life images look like. So they compared it with a dummy image versus real-life patient images. And to be honest, that's really what we need. Even though these images are not the greatest, even if you look at this example, I still think that we get all the relevant information that we need from getting this view. But there are alternatives. One of the other imaging view that I stressed upon last time also is getting a better view of the outflow cannula. And I would reiterate that if you could do just some other off-axis views to get outflow cannula and Dopplers of the outflow cannula, because they're going to be very relevant in the upcoming conversation about aortic regurgitation, how we quantify that. So one of the few other things that I wanted to mention is the device type. So the device type matters because if you have an HVAD, it will have a certain artifact which is called the waterfall artifact. And it basically blurs out all the Doppler imaging. And also it can look turbulent, but it's not really turbulent. It's just that hardware device has a musical sound and it can make it look like an artifact. And so the imaging parameters or imaging pictures that we get with hardwares are a little bit worse than other with the HeartMate 3 and HeartMate 2. The other thing I wanted to mention is that with HeartMate 3s, there's this intermittent reversal of flow, which is an set device. It's supposed to be that way. So I sometimes get a phone call about a reversal of flow in the HeartMate 3. That is normal because it is a washout mechanism by the HeartMate 3 in itself. So it can look like this reverse flow, which is a normal phenomena for HeartMate 3. So LV unloading. So first of all, I'm just going to go over some definition of what really LV unloading means. So basically, it's based on your hemodynamics and as well as your echocardiographic parameters. and we determined that using ramp studies. So what we do in the cath lab is we slowly increase the LVAD speed that is best tolerated by the patient till we get either suction. Suction means where the LV septum gets sucked into the inflow cannula. That's where we stop. Or if the RV starts getting bigger and the RV annulus starts getting bigger and you start seeing more tricuspid regurgitation, that has been described as a crossover point, which is where you're not supposed to cross over that speed and try to come back down like 200 or 100 RPMs below that speed is probably the optimal speed. Now, it varies from patient to patient because we have those ginormous LVs, which are 10 centimeters, right? And then their speed limit is going to be far higher. And then we have those ischemic cardiomyopathies, their LVs are usually smaller. And it also depends on the inflow cannula position. So if the inflow cannula position is off axis, meaning away from the mitral annulus and pointing more towards the septum, sometimes there is very limited speed increment that you can do, and they're running at very, very low speeds just because of that reason. So that's what we use in the cath lab, and the echo techs are usually good about telling us when they see suction, when they see the RV expand, and the tricuspid annulus getting bigger and more tricuspid regurgitation. So it's, to me, if the RV stays stable and you are unloaded, meaning your wedge pressure and your CVP is normal and you have adequate cardiac output, that is the optimal speed for that patient. So a lot of people ask me, do RAM studies make a difference? Now, there have been studies which were done to see when RAM studies were done on patients versus no RAM studies that were done on patients. So there was this European study where they looked at the baseline hemodynamics in a patient who never had a ramp, and it was inappropriate, like the hemodynamics were inappropriate in 79% of the patients, meaning their CVP was high, their wedge pressure was high. So those patients, 11 out of 20, had to go over their speed limits to actually attain a normal hemodynamics. So it is important, and it is also important in a timely fashion. So for instance, if you do one at the time of discharge, they may need another one in 6 months or so. And why could that be? One, of course, their RV overall changes. Once they've been on LVAD support for a long time, they may have worsening RV function, or they may have improvement in RV function. So there's a difference in how patients behave. So we may need to do these RAM studies at like maybe 3-month interval or 6-month interval or somewhere down the line. So by definition, if you're looking at echo parameters, what would define inadequate loading is that if you have a dilated LV or their left atrium is enlarged, if they have persistent secondary mitral regurgitation, if they have PA pressures that are elevated, and if their mitral EA peak diastolic velocity is greater than 2. And to me, if you're at an optimal speed, or the current opinion is the optimal speed is one at which the aortic valve opens intermittently, although I disagree with that a little bit because most of the times when we get them to a normal wedge pressure, the aortic valve doesn't open anymore. And there is this whole phenomena about whether more aortic regurgitation develops once your aortic valve intermittently opens versus not been proven. Then the interventricular septum, if it's midline, if there is mitral and aortic regurgitation are minimized, and their wedge pressure is less than 18, and the central venous pressure is less than 12. So mind you, important things that it's both cath and echo. Dr. Q.
So septum flatten, we see. Normally that means pulmonary hypertension, but in this situation, it could also mean excessive flow.
Right.
So I guess you want to hear about it. You want us to tell you the septum flatten?
I do want to hear about it. And I'm going to tell you why I want to hear about it is because I feel like in the last 1 year, since we have a lot of papers on 3D and volumes, and so we've had some insight into how the RV changes and the septum flattens, or the convexity or the concavity of the septum and the lateral wall changes. So that's important information. And I think in the future, how we, if somebody rewrites the echo guidelines, these are important things that would need to be determined.
But it's important since we have pre-established sentences that we do not say pressure overload because there may not be a pressure overload.
Right.
So it's important that we just say septum flatten.
Right.
Because if you click, you usually click, it's going to come out as a report of hypertension. And
Yeah.
this situation may not be more.
Right.
It may be excessive overloading.
Yeah.
So we have to be careful when we write that statement. We don't use the traditional statement.
Yeah.
That will say RV systolic pressure.
Right. So this was a paper that was done by Dr. Nagueh and Dr. Estep about patients who, what are some of the parameters that we looked at, and they're kind of more or less similar to the diastology guidelines where, we look at the E to A ratio, the RA pressure, the left atrial volume index, and they try to see what correlated with like a normal wedge pressure. So if your wedge pressure less than 15, what your RA pressure is going to be less than 10, the systolic PA pressure less than 40, your LA volume index less than 33, and E to E prime ratio of less than 14. So this is all good and dandy, and this is something that we practice in the lab very, it's a routine thing to do, and so I'm not going to spend a lot of time on this. But I want to talk about one important thing, is that there is a common misconception where you think that, okay, I can use echocardiogram to determine whether I'm optimally unloaded. That's incorrect. And that was, I'm glad they did this study, which is called the Ramp It Up study, where they actually compared, this is the first time that somebody did a randomized trial to compare whether your ramp study, which is your echo plus cath versus echo alone, is going to make a dent in the patient's overall outcomes, and whether they're optimally optimized if they're doing the ramp protocol versus just routine echocardiograms. So with this, what they basically did, this was predominantly HVAD patients. So what you see here is that this was the hemodynamic ramp group, and this was the control group. And the hemodynamic ramp group, they did baseline. They did 1 month, 12 months, 3 months, and 6 months. And then subsequently, they did a control group. And the control group just had a echocardiogram whenever the clinician wanted one, and just what their clinical acumen was telling them. And they noticed that there were a lot more hemodynamic changes that were done, or speed changes that were done with patients who were in the ramp arm of it versus in the control arm. The bars are showing the changes that were made in the hemodynamic group versus the control group. And then there were a lot of more medication changes that were done in the hemodynamic group versus the control group. So there was a lot more action going on in the ramp group versus the control group, which was just a echocardiogram to see. And so what they found here was that, patients who were in the ramp group, where they were being followed with hemodynamics and echocardiograms on regular schedule, their hemodynamics were better than the control group, which is by echo alone. And then the other important thing was that we now qualify outcomes in LVAD in different tiers. So tier 1 is where the lowest level of complication, and tier 3B is the highest level of complications, which includes pump thrombosis and disabling strokes. And if they compared those, they were also different. So there were a lot less in the control group versus in the hemodynamic group versus in the control group. So there is value to it, and there is value to optimizing patient, not just from a heart failure perspective. I'm going to say this, that a lot of these outcomes were driven by heart failure readmissions, but even outcomes like stroke, pump thrombosis, GI bleeding were better in the better hemodynamic profile patients. And so next is what I thought was really interesting is 3D echocardiography. So there was this study done, which was of 31 patients, and it included 19 patients with HeartMate 2 and 12 patients with HVAD. And device types, based on what device we're talking about, HVAD, we generally, if we make a 100 increment, it's a big increment. And if you're talking about HeartMate 2, a meaningful increment is around 400 RPMs. So after 2 minutes of stabilization, they did record hemodynamic parameters. And they continued the study until like the routine things. If you develop suction, if you reach the highest speed, and when your RV parameters worsened. And so they did volumetric assessments, and they did LV sphericity and conicity, and then looked at RV curvature as well. So I'm not going to go over details of sphericity and conicity, how they measure that, but it's an algorithm that they use, and they make a mesh and then compare to a control sphere and a control helix, and then see what the sphericity and conicity index is. So this was for HeartMate 2. The gray mesh is what was baseline, and then the inside of it, or the yellow and the red, shows what happened to the LV as the pump speed was increased. This is just one example of it. So in patients with HeartMate 2, when you increase your LVAD speed, they did increase their average volume did decrease in the LV. And the average volume increased by almost 20% from between the lowest to the highest speed. And the likely change that happened in the LV kind of shape is that the walls come closer But the thought is because the the inflow cannula is in the apex, the uh, the change from the base to apex is not a lot. So it's usually the walls that come in that cause the change. And what was happening with HeartMate 2 is also that they became more conical and less spherical with increasing speeds. And the averaged RV volumes did not change significantly. It was not as meaningful change, but it was a lot compared to HVADs. And they changed almost 60 mLs from the lowest to the highest curvature. And with increasing the LVAD speed, the curvature of the interventricular septum increased, becoming more convex and bulging into the LV. And when comparing the lowest to the highest speed, and the free wall curvature decreased at the highest speed. So these were and became more concave or flat. So what this is telling you is that my purpose of going over this is that if the interventricular septum starts bulging more towards the LV, and the free wall becomes more concave or more flat, that's meaningful information for me because that's telling me that maybe with the LVAD speed, we've crossed over to that point where we're causing significant changes to the RV shape and RV dynamics, which is probably going to hurt the patient. Because these patients over long-term support do develop RV failure, which is an important long-term complication in these patients. So similarly, HVAD, now this is an important difference to understand that HVAD do not behave in the same way, or the LV doesn't behave in the same way if you keep increasing the speed. So there was a little difference in their global sphericity and conicity. And overall, with increasing speed, their 3D volumes decreased a lot less than the HeartMate 2, so almost like 50 cc's versus 120 cc's in the HeartMate 2. And the LV sphericity was higher with HVAD, and that is thought because it's a pericardial pump, so it doesn't pull on the LV apex, so the shape of the LV is also different. And there was, if you compare the LV volumes, you would think that there's a lot less LV volume change with HVAD, yet attaining the same hemodynamics that a HeartMate 2 does achieve. So the thought is that it's a lighter pump and it sits on the pericardium, so it may be providing a little bit better, less change to the overall shape of the LV and RV compared to the HeartMate 2 in itself. And with the RV volumes also significantly increased with increasing the LVAD speed. But the magnitude overall of the change in RV size was also less compared to HeartMate 2. So is that what makes HVAD a better profile from in terms of hemodynamics? It's not been shown in long-term data where we don't know if HVAD has a better hemodynamic profile than HeartMate 2. So this is how the shape, if it changes. So this is 8,000 versus 10,000 RPMs and 2,200 versus 3,200 RPMs, comparing HeartMate 2s and HVADs. So this information, whether it becomes more flat or more concave or is getting sucked towards the LV, is important for us to make decisions whether the speed is too much or too little for the patient. So then what about HeartMate 3s? There was a separate paper that looked at the HeartMate 3s, and they did similar increments. And one of the pitfalls of 3D imaging, however, is that it's only feasible almost like 50 to 60% of the patients, particularly with LVAD. And so they saw that the LV and diastolic diameter does change 0.15 with every 100 RPMs. And the LV volumes behaved a lot similar to HeartMate 2. So the end diastolic volume changed from 269 to 175, and the end systolic changed from 234 to 146. And the RV volumes for a good number of increments in speed stayed the same, but at higher levels, the RV volumes then decreased. And on an average, the RV septum became less convex at the higher speeds. So the argument that whether that because it's also a pericardial pump, whether it behaves any more different than the HeartMate 2 still pertains, is relevant to this discussion. And the RV volumes, however, they change at much higher speeds. So one could say that if you maintain like moderate speeds with HeartMate 3s, they may overall not develop as much RV failure in the long run. But those are some important, insights, and these are just some figures to say that. So, No long-term data.
As far as cath data, is there anything that shows what these changes in RV shape correspond to in terms of PA pressures, RAP?
So no, so the when the changes in the RV occurred, there was one paper where they said that if the RV shape changes, it was a very small study, these patients also tend to have more mitral regurgitation and had higher PA pressures, and hemodynamics were not adequate, so the wedge pressure stayed elevated. But I mean, there is some link there, but it's not over long term, like many years, to say that whether it's better or not. But in my first, the ramp it up study, that showed that if you had better hemodynamics, not necessarily echo, shapes and stuff, but your overall outcomes in terms of even adverse outcomes like strokes or your pump thrombosis rate, your hospital readmission rate, all of it was better.
What is wrong with just taking care of patients based on cath numbers? So they are in the cath lab, you go up on their speed, you see a good cardiac output, wedge less than 18, REP less than 12, and everybody is okay.
Right. That's important, yet if I don't know how the interventricular septum is move shifting or how the RV looks, let's say if I went up from 8800 to 9600, and then the RV is all wide now, and the interventricular septum shifts, and the free wall is more concave, or that is important information to me. So that means I can't go up to that speed. So echo, cath alone is not going to be helpful. Echo information is important, but echo information alone should not be used to determine what's the aortic. That's my main mantra here. So I don't use echo on its own unless I'm worried about like one instance of looking at something. If I get information, I get concomitant echo and cath information.
With precision, it will be hard with echo to get the precise stroke volume, a precise wedge, a precise RAP.
Right.
It can tell you where they sort of fall, but it looks like you're titrating to certain values.
Right. So other things that do contribute to if you're not adequately unloaded is that if you're, apart from the pump settings, is if you have hypertension, if you have kinking in the outflow cannula, if your inflow cannula is malposition, and if you have continuous aortic regurgitation. So that, moving on to aortic regurgitation, last year, I said that there's speculated that aortic regurgitation leads to worse outcomes. And this significant lesion leads to just like a short circuit in the loop. And 50% of the patients develop moderate to severe aortic regurgitation at 18 months. I've seen it as early as a month. So I think that there is some discrepancy about timing also. But there is early AI, there is late AI, and when AI is present, it does portend poor prognosis. So these are some examples of LVAD AI, where we traditionally use vena contracta and JED with LVOT width. This is somebody who had 1 year post LVAD echo from basically 2010. They were at this time were NHY class 1 with no heart failure admissions and doing well relatively. At 2 years, this is what their echo looks like. Now they're getting heart failure admissions, and their NHY class has worsened. And if you look at the 3 year, this is rip-roaring aortic regurgitation. And, when it comes to this point, most people can tell that this is severe aortic regurgitation. There is, little doubt in anybody's mind that this would be, significant aortic regurgitation, even if you want to shy away from calling it mild, moderate, severe, because we don't know accurately how we quantify aortic regurgitation in these patients. And one other thing that goes hand in hand with aortic regurgitation is that if you have severe aortic regurgitation, you will also show signs of ineffective unloading, meaning your LV diameter is going to be higher now, and you may have the traditional signs of elevated filling pressures on echo. So there was this one study that showed that not only is significant aortic regurgitation worse, that leads to poor survival in patients, it is also linked to other poor outcomes. So for instance, like I mentioned earlier, we now tier them into how bad the outcomes are. So tier 1 is when they have just minor non-disabling strokes or GI bleeding. Tier 2 is when they have more than 2 GI bleeds. Tier 3 is when they have pump thrombosis and disabling stroke. So if you categorize them into those categories, patients who had aortic regurgitation also were found to have more of these tier 3 and tier 3B complications, meaning disabling strokes, which is still one of the biggest complications that we're dealing with in patients with LVAD. This is again one of the tables. I don't think it's showing too well. I'm sorry about that. But how do we quantify aortic regurgitation? That's important. So there's only one group that has looked into that, where what they did was they used gold standard of difference between cardiac output quantified by right heart cath versus LVOT TVI across the LVAD outflow cannula. And the difference between that was considered to be aortic regurgitation. It makes logical sense, but their gold standard is a little bit iffy. One could say that, cardiac output from right heart cath, how accurate is that in patients with LVAD? One. Two, a lot of times we don't get accurate LVAD outflow cannula, imaging, and then using that to calculate the LVOT in itself is a pitfall to start with. But in any case, what they basically said was that if you have a regurgitant, they looked at two parameters, which is the systolic to diastolic ratio at the LVAD outflow cannula. So what they looked at was basically the systolic to diastolic ratio, and they also looked at the diastolic acceleration time. So in patients who had significant aortic regurgitation, the systolic to diastolic ratio got smaller, and the diastolic acceleration time increased. And using that, they came up with two formulas to essentially quantify degree of aortic regurgitation. And how they corroborated that was with cath data. So patients who did have significant aortic regurgitation, they actually did have elevated wedge pressure. So over at least in the last 1 year, they've done is they've corroborated this regurgitation fraction with patient outcomes. So if they had higher regurgitant fraction, they had more hospital admissions, and they had more tier 3B complications if they had worsening aortic regurgitation. So the question whether we could incorporate this into our echo results, I think it would be meaningful, but the only problem that I see with that is the outflow cannula, Doppler imaging is hard. And a lot of times I don't see, at least good enough images of the outflow graft. Although I also think that we don't get the right views for the outflow graft. So that's one other important piece of information there. Now, in for according to them, if since these values do corroborate with worse outcomes, whether it's time to abandon the traditional parameters, I'm not sure about that. But they did compare it with vena contracta, and compared with vena contracta, these actually correlated better with outcomes versus the traditional vena contracta and jet width in itself. But the pitfall in itself is that they're using the LVOT TVI or the TVI across the LVAD cannula, and also the right heart cath data to determine aortic regurgitation as their gold standard. So I guess what we did in the last 1 year is we created our own mock model. And what we're trying to do is, at different speeds, we're looking at the aortic regurgitation, and this is an LV printed off of a real patient with a known with aortic regurgitation. And this is echo compatible. So what we are doing is that we have flow meters to determine accurate aortic regurgitation, and we can replicate, what they're doing, looking at the outflow graft velocities, as well as vena contracta and jet width to determine if this would be, against a known regurgitant volume, would it tell us exactly what the regurgitant fraction is, and whether we can replace the traditional standards. So this is, again, the echo compatible, and these are some of the images where we can see that there's some vena contractor there. We actually get very good Doppler images as well. So this might be additive, because if we use this and their systolic to diastolic ratio and diastolic acceleration time shows the same thing, then maybe we can replace our traditional standards of using vena contracta and jet width. So next is pump thrombosis, of course, and we traditionally use, of course, our hemolysis panel, our echocardiography data, and our cath data. But to be honest, echo alone doesn't necessarily help unless we go all the way to 11,000 speed, and I don't see any evidence of LV unloading, and the aortic valve continues to be opening at that higher speed. So one piece of information is not enough. And I've never seen a clot that we can see by echocardiography, neither by CT scan, because most of these clots are within the rotor and you cannot see within the rotor in itself. One other important thing to realize is that the pump thrombosis, even when it starts, it goes through different phases. So it could be a phase of fibrin deposition, then there's a phase of propagation, and then there's a phase where it completely occludes the pump. Now, when you have somebody in the fibrin deposition phase, I don't think echo can tell us unless they start showing some signs of worsening heart failure, and that would be a phenomena that happens quite early. The propagation phase is a little bit different. You may see some hemolysis signs like LDH is rising, so that might be helpful. But the real pump, when it's completely filled up, the entire inflow cannula and the pump is ready to stop, that's something that you won't even miss clinically. So I really don't need echo to tell me that. So the echocardiograms, in my mind, are more helpful for optimization. And then if there is some, maybe suspicion in the propagation phase, we can say that this would be helpful. And this was determined in the echo ramp studies. And what they looked at, basically the same LV end diastolic dimension, the aortic valve opening, the LV, the LVAD flows, to determine what is the, if they are not unloading with increasing speed, that kind of tells us that we're headed towards pump thrombosis. So this was first published by a group in Chicago, and then our own group with Dr. Estep determined and made this ramp study a little bit easier, because instead of doing like 100 increments, we went 8,000, 9,000, 10,000, and 11,000. And what we're really trying to focus in on, if you get a study that's for pump thrombosis, then LV end diastolic dimension, the aortic valve opening, the right-sided cardiac output, and the deceleration time. And we barely get that information sometimes, because I know that there's a lot of images that are required, but if properly done, these were associated and showed us better outcomes. And showed us that if there is truly occlusive pump thrombosis present or not. But most recently, we as a group have shied away from doing a lot of these unless there is some real clinical dilemma where we can't figure out whether this is pump thrombosis or hemolysis from something else. I'll give it an example. So I had a patient with cholecystitis, and his LDH was rising, and his LDH was 1,500. Now you can have a rise in LDH from gut, from having cholecystitis or anything else. In that situation, ordering this ramp study is probably relevant, because the most important discriminator is the LDH. If that is not helping me make that determination, then if I do the echocardiogram, then it would help me to see if truly the pump is unloading or not. And then documenting all these parameters is important. So I know this is what most people experience at the time when we are doing ramp studies, but like I said, most of them were doing it for determination of effective unloading most of the time, and less for pump thrombosis. Most of the pump thrombosis diagnosis is made clinically. But there are pitfalls to doing pump thrombosis, and what are those pitfalls? One is presence of aortic regurgitation can give you a false positive result. And this was studied in a study from a year and a half ago, where they looked at that the LV and diastolic slope, so to speak, that the LV doesn't decrease as much if there is aortic regurgitation. That's obvious, but they were able to prove that in this study. And the other thing is that if you have hypertension, then too the LVAD is not going to unload effectively, so kind of doesn't change the LV and diastolic dimension as much. And one other thing is, of course, the ramp study was falsely negative in 5 patients, and those 5 patients had poor outcomes. 2 of them died. So one echo alone should not be used to determine if somebody has a pump thrombosis or not. So you have to look at it clinically, and our heart wares are actually better at that because they also they come with waveforms, so we can now see the waveforms of these patients. So this is another example of a ramp study that we do in the cath lab. We do RA pressure, PA pressure, wedge pressure, and then sometimes we cross the LV also, particularly in patients who have some presence of mitral regurgitations or mitral stenosis, and look at the difference in the LVEDP and quantify transaortic gradient. So as the LVAD speed increases, the transaortic gradient basically increases beyond 20. And that is a point where there is complete uncoupling and is probably where the speed should be left at. Okay, so this is an example of a normal ramp response where you see that as the LVAD speed increases, the aortic valve closes and the LV and diastolic dimension decreases. As you can see here, there's an off-axis inflow cannula. And this is the M mode across the aortic valve is helpful because then we can see how long or what's the duration of the aortic valve opening. And this is where we define normal function, looking at the LV and diastolic dimension and also at the deceleration time. But I think we need to make a table in the echo lab to kind of quantify and write all those things down. This is for pump malfunction. Again, as you can see that at lower speed, the LVAD dimension was 5.8 centimeters, and it stayed 5.8 centimeters at the highest speed, which is 11,000. So a huge increment. Usually, the LV completely squishes down and compresses at that speed. This is an example of RV failure. So this is a horrible example of RV failure because this is a patient where when I increase the speed to only 4,600, this is in the early post-operative phase, the entire right ventricle became ginormous, no better word for that, and the LV completely collapsed. So this is an example of profound suction. And that usually happens in the perioperative phase. This happens more because we think that in the initial perioperative phase, the LV is still not used to having an inflow cannula, and suddenly you expose it to a negative pressure from the inflow cannula, the RV can sometimes completely fail. And clinically, this patient who had a SWAN present, his CVP went up from 5 to 25 with an index that dropped from 2.5 to 0.9. So this is a very drastic situation, and we had echo so we were able to capture this. Usually we can tell this by hemodynamics, and then we instantly changed the speed of the pump, and this suction was relieved. Again, these are some of the examples of RV failure after LVAD. This is an example of mild. I showed an example of very drastic, and these are, of course, severe RV failure. This is an example of our moderate RV failure 2 weeks post. So sometimes we will, need to know that, particularly in the perioperative phase, and also late onset RV failure is a real phenomena, and it is linked to poor outcomes and poor survival in patients with LVAD. So a lot of these patients develop late onset RV failure, which is 30 days post implant, and a lot of patients develop this after the first year of implant. This is where a patient suddenly got hypoxic after they were placed on LVAD. Does anyone know what that is? Yeah. So that can happen after they, again, images are not always the greatest when in the initial perioperative phase, but there's somebody who got hypoxic right after an LVAD was placed. So suddenly you have LA pressure that goes down a lot, and now you have a PFO that opened up and patient gets hypoxic. And this, in my limited experience, I've seen it 4 times now already. This is very common after surgeries.
It's not part of the pre-op evaluation.
It is, but sometimes it's not evident in some of the echocardiograms earlier on.
The mere presence of concern because that hemodynamics will develop after the LVAD. So it may be, if present, then the surgeon at the time of the LVAD implantation can close it.
Usually that's what they do,
Yeah.
and and this becomes very evident very quickly. So it's usually sometimes even in the OR that the patient hasn't left the OR and they suddenly get hypoxic, so they can fix it right away. This is an example of another patient who had suction and was miserable with suction because every time he would stand up and pee, he would have suction events because your interventricular septum, there is not just the inflow cannula that makes a difference, but also presence of things like Valsalva can make the inflow cannula, can cause the interventricular septum to shift towards the inflow cannula.
So what are the criteria for suction? Other than you look at it, it looks like suction.
So, you know,
Specific criteria for it?
so people say that the specific criteria for suction is when they have a suction where the inflow, the septum gets sucked into the inflow cannula. You have a drop in speed because suddenly your inflow cannula gets occluded. So you may or may not see a change in the LVAD speed and the flows. And the third thing that happens is a lot of patients can get VT. Although I would say that that leads to a lot of, you don't have to have presence of all three, or you can have just one, meaning if you have the echo feature of it, that means that they're having suction. And they can get symptomatic, like they'll get dizzy. It really also depends on how long the suction lasts. So if somebody had suction for a good like 30 seconds, it will be more meaningful as compared to somebody who had suction for only 5 seconds. So some people are very stringent about that definition of, presence of VT and dizziness, and I kind of disagree with that because we've missed a lot of patients with a lot of suction because we said, okay, they didn't have VT, or they're not having any symptoms and they're not having speed drops, because it can be a very transient issue that happens for less than 3 seconds, let's say, and then it goes away. But I think the most important part is imaging to tell you if there's suction or not.
How small is the LV usually? Less than 4, less than...
So every LV is different. So if you're starting off from somebody who has an LV and diastolic dimension who was 9.7 centimeters, I'm not trying to achieve 4 centimeter LV in those patients. So to me, as long as you can get normal wedge pressure and RA pressure at an adequate speed, with the interventricular septum interaction, which is appropriate, and the RV is not getting dilated and there's no regurgitation.
But for suction, what do you want to see?
For suction, I want to see the inflow cannula.
You want to see what? An LV down to...
No, I just want to see the wall getting sucked into the inflow cannula physically.
Well, you have an example?
Yeah, this is an example. So you see this is the wall getting sucked into the LV septum. This is the inflow cannula, and this is where the myocardium is getting sucked in and completely occluding everything. Do you appreciate it, Doctor? This is a very good example of suction. So this is like the mother of all suctions, because you see this whole wall, because the inflow cannula is pointing this way, and this is the myocardium, and the entire thing gets sucked in.
So part of it is, it depends on the size of the LV, but also depends on the location of the cannula.
Right.
So during placement of the cannula, does the surgery usually proceed with imaging or not necessarily?
They have no control over it, because what happens is they put put the cannula in, and once they close the chest, the complete position changes. So even if I was trying to be innovative and I was trying to tell them where to put the cannula in by looking at pre-op CT scans and doing like mapping for them, it never, so far. Yeah, once the chest closes. So Dr. Q, this is another example of suction. You see the whole LV is squished, and this is the entire RV. Now this is a drastic example.
Dr. Kassi, quick question. So is this suction event less frequent with the centrifugal pumps or no change?
No, it's actually, in some patients I see a lot more. A lot of patients have a lot of suction, which I think again has to do with the LV-RV interaction, and also how the offloading affects the RV dynamics and the RV shape. So suction is, I used to think of suction as just, okay, they have suction, they have dizziness. Now I think of suction and poor RV dynamics. So it has a lot of implications. Yeah. Because a lot of people will not have suction in the first year, but they'll start having suction in the second year, and that's usually because the RV is big. And more and more of the septum deviates. These are some of the complications. So which is why sometimes we order echocardiograms. So if somebody's having low flow alarms, so that could be because of suction, RV failure, tamponade. Tamponade is common right in the perioperative phase, where then we start patients on anticoagulation and they just had a surgery done, and you close the chest. That's the time when they'll develop tamponade. And interestingly enough, for LVAD patients, it doesn't take a lot of volume to cause significant tamponade physiology. So it's not the same tamponade physiology that you see with other patients. You'll just see a compressed RV or a compressed ventricle that would basically lead to ineffective unloading. This is an example of such, where you could see that there was significant pericardial effusion. Although it seems small, it can cause a significant compression. So we placed the patient on inotropes. There was some improvement in their hemodynamic status. And again, this is another example where you can see that it can compress. Even small amount can cause a significant effect on the hemodynamics. Next, I don't know how much time we have left, but I was going to show some views that we did with ICE, with the LVAD. This is where, again, things that are important to me. So interatrial septum, the outflow graft. And I think one of the best views of the outflow graft was with ICE. So, almost begging to the point that maybe doing hemodynamics cath, right heart cath with ICE is also maybe one way to circumvent the issue of poor imaging. And again, this is a view where we could see the aortic valve, root thrombus, RV size and position. Again, the RV is completely squished in this situation, and the LV is huge and it's bulging towards the RV. So this is a situation where it's ineffectively unloaded. And the notion of doing LVAD flow or output using RVOT flow or LVOT flow. Again, if we have good RVOT images by echo, we can use that. But I don't encourage using that because it can also be very misleading. But there were good views that we can get through ICE imaging. And again, this is where we can see the mitral annulus very well, the inflow cannula position, and how that is relative to the mitral annulus. And this is tricuspid regurgitation. Again, the degree of tricuspid regurgitation, the RV, and the RV function is important. And this is an example of how the outflow graft, I don't think we can ever see the outflow graft this well on echocardiogram. Although now that, I've looked at some of the other images from some other centers where they've tried some off-axis imaging of the outflow graft, maybe we can try to get these into view and get better views of this, because we do experience a lot of issues with LVAD unloading because of the outflow graft, where it can get kinked or it's obstructed. And for, of course, the quantification of aortic regurgitation, it's important to look at the outflow graft and the Dopplers through the outflow graft. Again, this is aortic regurgitation, somebody who has 3 jets with AI. So, echo is helpful, again, but, along with that, why we do it, predominantly for ramp studies for hemodynamic quantification. Pump thrombosis, we're using echo parameters far less. And then, of course, for troubleshooting complications and trying to figure out why people are having low flow alarms are most of the important reasons why we do echocardiogram. I think this is just an example of a descending aortic graft and thrombus. That's pretty much it. Are there any questions for me?
When do you require additional imaging, say with CT?
So we do it in all our patients who present with a complication like a stroke. So that, and then we are doing it surveillance-wise too, to assess the inflow cannula position and the outflow cannula position. And let's say we are increasing the LVAD speed and we don't see a hemodynamic change, then we do it for outflow graft and kinking also.
So you said you do it routinely, or you do it in situations when you are not seeing the expected responses to what you're changing the speed?
We're doing it routinely as well as, yeah, as well as for any changes that happen.
Were there situations where you say clinically things were fine, whatever you got by echo was sort of within your expectations, and then when you did the CT, unexpected findings occurred that altered management?
Yes, in situations where we thought that the LV maybe was foreshortened and we couldn't get a good image, and when we did the CT scan, the LV volumes were humongous or the RV volumes were humongous, we could see that. And then outflow graft related issues or something we could better see with CT scans.
So you would recommend it at least once after the LVAD is implanted?
Yeah, so what we do is that we do hemodynamics and we do echoes, and then we do CT at the same time. So this way we have better information of the, concomitant anatomical as well as echo information and hemodynamic information.
And as far as cath, this is also, you were saying, part of their routine that you will do for them within 6 months or so?
We do it prior to them being discharged.
Prior to being discharged, so you get sort of a stable set of values, and then if you see them clinically and they are fine, would you consider repeating cath again or no?
If they're doing fine, we don't typically do it. If they're having complications or if we think that we can't determine their fluid status or RV function by echo or by clinical exam. So one thing I would say here is that when we're examining patients with LVAD, they all have elevated JVP, regardless. So and they will have, rapid X and Y descent sometimes. So it's really hard to determine what their actual CVP is by just examining them. So that's why a lot of patients, when we start putting them on diuretics and their renal function starts getting worse, and they're clinically not feeling okay, then we'll do a right heart cath and echo as well to determine what their RV function is looking like. Do they need speed optimization? Do we need to increase the speed? If they have like symptoms of fatigue and shortness of breath, then we'll also do a right heart cath and echo.
You showed a hemodynamic study that compared just control
Echoes.
versus something guided by cath and imaging at intervals.
Right.
And you show different uses of medications. Is it not the goal that whenever you can maximize medications in this LVAD population, you should do so?
We try, particularly in the non-ischemic. So there's been a couple of patients where if they're non-ischemic cardiomyopathy, we try to optimize, and they're drug naive, but they present with end-stage features. So we can't put them on any medications anymore, and they're like literally dying of cardiogenic shock. In those patients, we'll put an LVAD in, and then we'll try to optimize their medications to our best ability. So some of them have recovered, but these are generally just non-ischemic cardiomyopathy patients that they recover their LV ejection fraction.
I asked the question because I saw it in the study that you showed a different use of beta blockers and ACE and so on in the group that had the cath. If somebody were going by, say, a goal-directed medical therapy, and I'm trying to maximize medications, at least with respect to the beta blockers and ACE inhibitors, you would not think that there should be a major difference, perhaps in diuretics. But that apparently was not the case.
So basically what they saw was that GDMT was more common when you were doing the ramp. If you were in the arm where we were following your hemodynamics closely, then you were more likely to be placed on GDMT versus people who were just being followed with regular echocardiograms.
I take it BMP not reliable in this population for anything.
I use it in certain situations, not in every situation. Let's say for a certain situation being like they are, presenting with, let's say, fatigue or decompensated symptoms, and it's hard to determine their volume assessment, just if you haven't done a heart cath yet. So in some instances, rarely I'd order a BNP, and if it's super high, then it means that. But no study has been done to corroborate a normal BNP versus abnormal BNP or cutoffs for these patients.
So you're looking at absolute value, not necessarily comparing it to what it was before.
The comparison is important, but also like if it's in the thousands, then it's more relevant than versus it's in the few hundreds. But there's no cutoff. Like everybody is a little bit different, and how a lot of times I don't look at BNPs. I only look at very rare instances of BNPs. All right, thank you.